In part one, we learned that the 10-year risk score your doctor uses is a statistical guess. It's extracted from observations in a population. We learned that even if you are labeled high risk, your actual odds of staying event-free can still be 9 to 1. The problem is these scores don't tell us if we have the actual disease. To find that out, we need the coronary artery calcium scan or CAC scan. This is an imaging test that finds calcified plaques in your heart's arteries. These plaques are the late stage and irreversible sign of atherosclerotic cardiovascular diseases. Now consider these plaques as battle scars from a lifetime of exposure to unfavorable lifestyle choices, but also to conditions you mustn't blame yourself for. Genetics, for example, aging itself, then also autoimmune inflammatory conditions like lupus, for example. Now, ironically, those calcified plaques are not the ones that typically cause a heart attack. It's the rupture-prone soft plaques, which the CAG scan can't even see. But, and this is the key, the more of these battle scar plaques you have, the more likely it is you also have their more dangerous soft plaque precursors. It's like in a lottery. The more tickets you have, the higher your chance of hitting the jackpot. The CAG scan tells you how many tickets you are holding. And that's why the number 0 on a CAG scan is so reassuring and, as we will see, surprisingly common. A CAG score of 0 immediately drops your risk, in most cases, to below that 5% threshold that triggers your doctor to bring up statins. And that applies even to people who already have obstructive coronary artery disease. But a CAG score of 0 doesn't mean you can walk away and think you are fine for the rest of your life. A 0 score comes with a, say, limited warranty period. In my post, you will see how to estimate that warranty period for your specific ethnicity. So, for example, if you are a white male and your CAG scan shows 0 calcification, your chance of having a CAG score greater than 0 after 3 years is roughly 16%. That means 5 of every 6 men will still be 0 3 years after their first 0 scan. And 0 isn't rare, which is the amazing part. Over half of all individuals who are to be considered for a statin, according to guidelines, have a CAG score of 0. But what if it's not 0? Okay, the bad news is once plaque starts, its progression is almost inevitable. But the good news is it's predictable. And I've translated the research from the Heinz Nixdorf recall study into a simple graph you can use to predict your future. Now let's walk through this. It's simple. First, find your current age on the vertical axis. Then move to the right until you hit the curve that represents your current CAG score. In this example, your age is 60 and your CAG score is 100. So from that point, you look down and find yourself on the 61st percentile. That means 61% of men your age have a CAG score of 100 or less. Now, stay on that vertical track and follow it up until you hit the red CAG 400 line. Now look back at the age, it's about 71. This tells you and your doctor that you have about 10 years until you cross into a much higher risk category. This is why the CAG scan is the ultimate tiebreaker. It gives you a much more precise risk estimate. In fact, it reclassifies about 1/3 of all patients. And 2/3 of those reclassified people move down to a lower risk group. But the CAG scan has limitations too. It's not reliable for young adults, also those under the age of 45, because, as we said, it's blind to the actual triggers, the soft plaques themselves. And in young adults, they don't have enough time to morph into their calcified end stage. So what if you are young, or what if your CAG score is 0, but you still feel something might be wrong? How do we find the soft plaques? And what about the genetic wildcards that your risk score completely misses? That is exactly what we will cover in part 3.